moving on to high altitude pulmonary edema. This is essentially defined as a non-cardiogenic pulmonary edema in previously healthy people ascending rapidly above 3,000 meters. It's not just us who live at low altitude and trek to high altitude that can get high altitude pulmonary edema. It also can occur to high altitude residents who go to live at low altitude for a while and then return. And usually it takes about 7 to 10 days for them to become at increased risk of developing this. The incidence is a little bit unclear. As with everything in altitude medicine, it's always hard to get good statistics, but it's estimated as being somewhere between 0.5 and 4% of people who travel over around 3,000 meters. One study in 2010 suggested that somewhere in the order of 2% of air travelers to Tibet arriving at altitudes of around 3,600 meters would develop high altitude pulmonary edema, although I think that's somewhat of an overestimate. The definition of HAPE is, in the setting of a recent gain in altitude, you need to have at least 2 of the symptoms listed here and at least 2 of the signs. The symptoms are dyspnea at rest, cough, weakness or reduced exercise tolerance, and chest tightness or congestion, and the signs are crackles or wheezes in at least one lung field, central cyanosis, tachypnea, or tachycardia. Again, as with the Rake-Ruiz score for AMS, you can see that some of these features are relatively non-specific, but it's the best definition that we have. Generally speaking, HAPE doesn't occur until about 2 to 4 days after arrival at high altitude, and it may or may not be preceded by a period of AMS, and it may of course be associated with HACE on some occasions. Generally speaking, as with all cardiac pulmonary edema and non-cardiogenic pulmonary edema states, the hallmark of HAPE is shortness of breath on exertion. There may be chest pain, there may be a dry or moist cough, and you may in fact cough up frothy sputum in the same way that somebody with cardiogenic pulmonary edema might. Gradually, because of progressive hypoxia, you become increasingly confused and delirious, cyanosis becomes evident, and your SATs become substantially lower than you would expect at a given altitude. You become tachycardic and tachypneic, you start to hear creps, particularly in the right middle lobe, although that's not quite understood as to why specifically that lobe is favoured, and from there on, it's a picture of progressive respiratory failure and worsening gas exchange. The pathogenesis is complex, but I want to keep it simple here for the purposes of this talk. Basic principles: alveolar hypoxia leads to uneven hypoxic pulmonary vasoconstriction that results in pulmonary hypertension and an uneven increase in capillary pressure. Ultimately, that results in stress failure of some capillary walls, and as a consequence of that, those walls become leaky and you get a patchy high permeability edema state. You also expose basement membrane when the capillary wall breaks down, and that effectively results in a whole range of inflammatory mediators being activated. A whole lot of inflammatory markers become released, and there's also a degree of intravascular thrombosis that occurs. Another thing that occurs is that hypoxia may induce systemic endothelial failure in HAPE-susceptible subjects, and that may contribute to nitric oxide synthesis failure. And what we do know is that exhaled nitric oxide is lower in HAPE-susceptible individuals at high altitude, and we know that Tibetans, for example, who are acclimatized to functioning well at high altitude, have high levels of nitric oxide, and they are probably genetically blessed with the ability to produce more nitric oxide because they have genes that assist them in coding for nitric oxide synthase. What is nitric oxide? Fundamentally, it's a powerful vasodilator, and therefore it can cause pulmonary vasodilatation in the context of hypoxic-induced pulmonary vasoconstriction that allows a smoothing out of ventilation-perfusion mismatch and allows for effectively better oxygenation. So nitric oxide certainly probably plays a significant role in the pathogenesis of high-altitude pulmonary edema, and indeed it probably has a potential in the treatment of high-altitude pulmonary edema, although of course the utilization of nitric oxide in the field is exceptionally impractical. And As we talked about with AMS previously and acclimatization in general, there are obviously quite a number of genetic associations which are still being explored, and we clearly don't have definitive answers to that yet. Okay, the treatment for HAPE is always descent. Descent, descent, descent. And really, you probably need to descend these people fairly quickly, and they may well need to be descended at least 1,000 meters or more, certainly at least to an altitude where they start to get significant resolution of symptoms. If you have oxygen, you should make it available and target their sats to be greater than 90%. If you had a hyperbaric chamber, as we illustrated before, there may be a potential benefit. And CPAP would be effective. Remember, CPAP is an effective treatment for pulmonary edema states in hospital, and obviously there's no reason why it should not work here, but it's not practical to have CPAP available in the field. Some mountain guides actually recommend that the patient or the victim try to breathe through pursed lips during descent, because that, in a way, is a form of introducing some artificial PEEP, which may be of some benefit. And there's probably some value to that. Drugs certainly can have a significant benefit, and nifedipine and sildenafil, which you'd otherwise know as Viagra, are potentially of benefit. Why is that? Because they are essentially pulmonary vasodilators, and as we said before, the fundamental pathophysiology at play here is pulmonary vasoconstriction. So if you have drugs that can reverse that, they can be of significant benefit. So nifedipine is the drug of first choice, and sildenafil is a reasonable and viable alternative. Dexamethasone has no real benefit for HAPE, but should be administered if you suspect that AMS or HASTE coexists with the patient's HAPE. Salmeterol is a bronchodilator drug which has also been deemed to have some benefit in HAPE, but it really is a third-line therapy, and we've already talked about inhaled nitric oxide. It would be effective potentially, but totally impractical to utilize in the field. Notably, there's no role for the use of acetazolamide in treatment doses or the use of diuretics in treating HAPE.